Good morning, and thank you for joining the Patient Family Education and Marketing Communications teams from Children's Hospital, Los Angeles for the presentation, Health Literacy, Patient Education, and Marketing Lead to Effective Communication. Just a few housekeeping. I'd like to ask that you save and reserve chat for comments and use the question and answer for any questions you'd like to ask during the panel discussion. As time allows, we are also hoping to have some interactive discussion, and we will be able to use the raise hand and call on people to connect with us at the end of the presentation. And then questions will be reviewed through the Q&A at the end. So we're going to start off with our objectives for today, which are listed here. And as we get started, we have two poll questions we'd like to ask all of you. First, we'd like you to let us know what your role within your organization is. You should have your first question here on the first slide: clinical care provider or nurse, health educator, researcher, administrator, communication specialist, or other. Just give everybody a moment to answer. So it looks like as people are continuing to answer, we have a fairly even distribution if we want to share the question. Can everyone see the question? So it looks like we have a pretty even percentage of all different groups. If you selected other, we would really appreciate if you could enter in the comments what your specialty areas or what your work area is, so we can kind of see who's represented today. Moving on to the poll question number 2. We'd like to get a baseline of what your current practice is today. So on this question, we'd like to know if you currently work with a patient family education team, or if people are working with you, if you work with your marketing communication team, you work with both, or you work with neither. We'll give everybody a few minutes to answer. Okay, looks like everyone's had time to answer. So it looks like quite a few of you do work with a patient family education team. If we want to show the poll, I don't know if everyone can see it. You can see that we have about most people are working with a patient family ed team here. Some are working with a marketing communication. Some are 20% are working with both, and about 20% work with neither. So when we are done today, we hope that you all see the value and have some additional tools to start and continue or strengthen your collaborative conversations. My name is Sandra Mintz, and I am the Clinical Services Manager in the Office of Patient Experience, and I manage our Patient Family Education team, Family Resource Center, Patient Family Engagement Opportunities, and Interactive Care Technology for Patients and Families. I've been working with Children's Hospital for 24 years, and we'll be sharing our experience towards achieving organizational health literacy. I'd like to begin to review the definition by reviewing the definition provided by Healthy People 2030 as it pertains to personal health literacy. Health literacy is the degree to which individuals have the capacity to obtain, process, understand basic health information and services needed to make appropriate health decisions. As you know, this involves the individual's skills and abilities as well as age, culture, education, and language. For the purpose of this discussion, and our aim is to discuss how our collaborations are facilitating our growth to optimize organizational health literacy. Healthy People 2030 defines organizational health literacy as a degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. An important factor in any healthcare setting is to remember that before someone walks through the door of your organization, they've likely heard from well-meaning friends, family members, completed Google searches, reviewed Yelp, looked at social media, and if they're our younger generation, they'll likely go straight to TikTok. Whether it's themselves or someone close to them, their very first opportunity for information to be provided is the organization's digital front door through apps, website, and social media presence. How many of us have worked in environments that you feel like you are in a silo working from your own tower. Feel free to add into the comments. Breaking down silos and building bridges to open lines of communication is the first step in any work efforts for organizational health literacy. Why is organizational health literacy important? Patients and families have continued to provide feedback that they want a consistent experience throughout their continuum of care, starting with their first exposure along their journey. Breaking down silos and working together ensures organizational alignment, which decreases redundancies in work efforts across the organization. Having alignment between the teams developing and reviewing content across the organization ensures that patients and families receive information that is consistent, readable, understandable, and in their preferred language. The result, improved patient-family outcomes, satisfaction, and experience. With the added bonus, it meets regulatory requirements. You may be asking yourselves, how do we get started or continue to build the relationships? I like to refer to this as building the village, starting through engagement, communication, and collaboration between patient family education and marketing communications teams. From there, we can circle the wagons to include our language and cultural service teams, print shop teams, who are frequently the first to see newly developed content in the organization when it doesn't come to our teams. From there, you bring in your facilities, guest services, patient experience, clinical excellence, staff development, quality, compliance, regulatory, research, and clinical teams across the organization to continue this journey. In those early stages, we found establishing regularly scheduled meetings every 2 weeks between our team members, discussing and educating each other on how our work and processes are in order to identify opportunities to align and develop collaborative processes. Once doing this, we were able to create roadmaps that others could follow and begin to engage other stakeholders. Since that time, we've developed educational opportunities for all team members to become the shared voice to consider health and digital literacy and numeracy when creating content or new methods of communication for patients and families. Last and not least, taking the information and tools we've identified or developed and having it in a form that is accessible for content creators across our organization. It's through this shared vision and goal we can achieve organizational health literacy. I'd like to now invite Jacqueline Grace, our Senior Patient and Family Education Training Specialist, to discuss applying health literacy to patient family education. Thank you.
Thank you, Sandra. That was a mouthful. My title is always a mouthful. In a world where I try to use plain language and use as few words as possible, it's just ironic to me that my title is so long. I'd like to get started with pointing out the social determinants of health as listed here in the graphic from Healthy People 2030. And the reason I wanted to start with this is because I feel that this has really helped to amplify the not struggle, but the goal to have organizations really listen to and appreciate the fact that health literacy is important. Healthy People 2030 has elevated the importance of health literacy by declaring it a foundational principle and overarching goal, and by adopting 2 definitions that together consist health literacy, which Sandra illustrated for you initially. And health literacy falls under the healthcare access and quality domain. Importantly, there are some objectives. These are all related to health literacy, but of the 6 that are listed, 5 are really related to patient education. The objectives are to increase the population of adults whose healthcare providers check to their understanding, which we all aim to do in a healthcare setting, to decrease the proportion of adults who report poor communication with their healthcare provider. Another objective is to increase the proportion of adults whose healthcare providers involved them in decisions, the shared decision making, increase the proportion of people who say their online medical records are easy to understand, and to increase the proportion of adults with limited English proficiency who say their providers explain things clearly. I would even expand this to include all adults, limited English proficiency or not. The goal is to increase the proportion of them who say that their providers explain things clearly, And of course, the last one is a little harder for an institution to do on its own, but it is to overall increase the health literacy of the population. So what we found very helpful, there's been a multifaceted approach to our health literacy efforts at Children's Hospital Los Angeles. We've created this toolbox for team members. There are different ways that we've approached this. One of the ways has been to produce and to provide health literacy in services, which is really just myself and colleagues visiting with other team members, other departments and units to introduce what health literacy is, to really get them to understand and appreciate health literacy and how important it is in a patient education setting. We've also presented health literacy grand rounds, which include our broader community of faculty and other roles in the organization. We've also created health literacy iLearns, which we call them iLearns. They're online team member training. So they're self-learning modules that anyone can go through at their leisure and learn more about. We have 2 so far, so they learn more about what health literacy is, like an introduction to health literacy, as well as a follow-up or a part 2 iLearn, which gets into the ins and outs of creating health literate patient education materials. We do have an upcoming 3rd iLearn in our series, which goes over verbal interactions, health literate verbal interactions. We have very helpfully, thanks to our colleagues, been included now in the RN, our Registered Nurse Residency Education Program, so that anytime there's a new cohort, we have an hour dedicated to health literacy and an hour dedicated to patient education. We have found it super helpful to have a central location to house all of our health literacy materials, being content that we've created that we have reviewed for readability, but also tools that help people create health literate content. And Kelly will go over a little more about our engagement site. We have a patient education readability review, which goes over every document that is created at the hospital so that we can review it for literacy. We also consult with our teams, and we've offered that as a new service so that right from the start, they can get started on creating content that does have health literacy in mind before it is created, to facilitate our roles in that we have less time-consuming information or content to go through and to review and edit. We have helpfully provided some content development guidelines, which go through the ins and outs of how to create everything from font size to formatting and all of the inclusive elements that help create content that is easy to read. We are also leveraging the literature. So we have a group of professionals who understand that health literacy, they've heard of it to some extent, but it's easier to help everyone understand how important health literacy is by using the literature. So providing information on studies that have assessed health literacy of patients and caregivers. We also use studies that have assessed stress levels of caregivers. In a healthcare setting, of course, the learners are often stressed and nervous about either their own healthcare journeys or, in our cases, that of their children. So it's helpful to provide all of this information to build towards a better appreciation and understanding of why it's so important to take health literacy into account. This graphic is adapted from an article that's cited at the bottom by Dr. Ruth Parker. And it shows where the convergence is of skills and abilities that patients or learners bring to the table. The demands and complexities, not only of the healthcare organization, but of the insurance industry, as well as the demands and complexity of the topics that they're learning. Also the psychosocial elements and environmental factors that can have an impact. And the acuity, or if they are in a crisis situation or how acute the situation is. All of those things combined make up a person's health literacy or have some kind of impact on it. This is a really helpful slide that I'd like to share during some of the in-services that I provide. in that it allows a person to try to read just a small paragraph that has been jumbled. I'll give you a minute to read it. Okay, so this is PICC line care as perceived by a parent with limited literacy skills. We've now helpfully unjumbled the words for you, and you can read that it says, be sure that the syringe does not have any air bubbles by pushing slightly on the syringe until saline is visible at syringe tip. Now, before this, you may have gotten maybe halfway through and really did your brain, it took your brain a second to unjumble the letters and to realize what word it is, but eventually you got through some of it and maybe you were able to understand what you were reading. And this is very similar to how someone with limited literacy skills, just the literacy alone, they maybe a person that doesn't read very well, didn't get too far in school, wasn't able to pick up those skills, how they might feel when they're reading information, health information that's provided to them. And so I found that this kind of slide or this kind of experience really allows the provider to gain a deeper understanding and appreciation for what the learner is going through at the time that education is being provided, which oftentimes, again, is because their child is in an acute situation, they're in an emergency room, what have you, a new diagnosis, and the learner is just that much more stressed and it's hard to understand certain materials. So the instructions or the helpful tips that we provide during our in-services as well as through our toolboxes is to give clear answers. All of the health literacy tenets that we are familiar with, we invite people to assess their own abilities and to recognize when to collaborate with someone else, specifically with our department. Do they need more tools on how to create new education materials, or do they need just a few tips on how to present information during a new class that's being developed? We encourage them to look for signs of limited health literacy that may not be obvious to a person that is new in the setting or that has just met a patient or their caregiver, and really instruct them on how to pick up on the hidden signs that someone may be having trouble understanding the information that's being provided to them. And of course, we always encourage everyone to make it a point to share their observations along the continuum of care, so that what one person discovers can help another provider later on down the line provide better care. We encourage everyone to identify or to know their audience. And that goes for healthcare providers and staff as well. If they see a colleague who may be having some trouble or maybe just doesn't quite understand how to communicate with patients and caregivers, to follow along and provide information that has been helpful to them. Also, our institution is big on the teach back method, which is taught, I think, to most nurses in nursing school, but it is just a great method to understand or to get feedback from the learner to really assess whether they have understood what they have just been taught. And one of our favorite toolkits to provide and to point people to is the AHRQ's Health Literacy Universal Precautions Toolkit, which is very robust and has a lot of different helpful tools in it. Some solutions that we have come together, or I would say another set of tips, is to recognize that sometimes certain labels underlie health literacy difficulties. So you may have heard these are terms like non-compliant or difficult patients or caregivers. We're really trying to step away from that for many reasons, but among them is because whenever a person has a label like that applied to them, it could go back to whether they are able to understand what was the information that was provided to them. So in order to communicate effectively with patients, sometimes we encourage people to communicate differently. That is to say, certain tips help providers to remember that not everyone they are speaking to is familiar with terms like MRI or X-ray, which people have heard but maybe are not truly familiar with. So we always encourage people to avoid using acronyms, avoid plays on words which don't translate well. We have found that in our work, it is important to keep in mind that our English materials will be translated eventually into other languages. So it is really important to keep away from things that are not going to help the translators with the work of communicating what we are trying to communicate in English into other languages. And working with partners is especially important. As an example, our pain team worked with us to develop a series of smart phrases, as we called them, to really make sure that some of the phrases that they often use in their discharge instructions were written in a readable way. So they put together a list of about 40 phrases that they often copy and paste into their discharge instructions. We went through them and reviewed them for readability and provided the same information, but just in a more readable format so that they can begin using those phrases with their discharge instructions. And they have reported a lot of success with it in terms of what their patients have reported understanding and following instructions in their discharge. Another helpful partnership is with our patients and caregivers themselves. So we have created a content review board, which helps us review a lot of the material that gets submitted to us for readability. And it's nice to have that patient caregiver feedback so that when we develop information that we think is very helpful and educational, to make sure that the end user does indeed have input into that particular piece of content. We've also provided some tools for our institution, for our members to become more familiar with how to develop written education. So on the list here, it's just a few. There are many other readability assessment tools that can be used, but the ones that we have used at the hospital, we've noticed that are most successful in helping our goals are the Hemingway app, which you see listed fourth in the on the list here, and Flesh Kincaid. Now, Flesh Kincaid isn't the best. If you have any experience using these tools, you likely have noticed that Flesh Kincaid may not be the most accurate, but for those who are not familiar, Flesh Kincaid is a feature built into Microsoft Word. And the reason we use both of these, the Hemingway app and Flesh Kincaid, is because of their accessibility. So they're already included in Microsoft Word in the Flesh Kincaid. And then the Hemingway app is free on the web. There is a downloadable desktop version, but it's also very easily accessed by anyone who has an internet connection. So for the our staff who are working on different pieces of education, it is helpful to just use some of these to help them get started on already assessing the content they're developing, and to keep an eye on it. Very helpfully highlights what some trouble areas by highlighting in red in their text what needs work and where they should focus their efforts on to improve the readability of their materials. Another one I'd like to point out here is Readable Pro. And the reason for this is because my manager, who was Sandra, spoke right before me, she has found it really helpful in showing to our leadership, because Readable Pro does provide reports that assess the different formulas that you see on the screen. They assess the content that is provided to us, and it very helpfully has visuals that it gives a grade level to each document. So she's been able to show this at leadership meetings and really can speak to how helpful a piece of information is, how readable it is. Grammarly has also been helpful in our goal to avoid or minimize the amount of plagiarism that may accompany some of the documents that are produced at our institution. And sometimes there's self-plagiarism, oftentimes, but it's just any instance that may be something similar already existing. This helps us identify it as well. Other resources that we've found helpful, that our staff has found helpful, is the CDC's Everyday Words for Public Health Communication website, as well as the Plain Language Medical Dictionary that's available through the University of Michigan, which is a lot more focused on medical language and converting it to plain language. Now to speak with you about branding and the patient experience and education and where health literacy meet is our own Kelly Carolipio.
Hi, everybody. My name is Kelly, and I'm the Executive Director of Strategic Content and Marketing Communications at Children's Hospital Los Angeles. I have the privilege of overseeing our brand strategy as well as our content development for both marketing materials and internal communications. I also oversee our photo video teams and our design teams as well. So there's really some intersections that happen that I'm very excited that we've been able to partner with our colleagues in patient experience and patient family education on some of these efforts. I drag here. So since not everybody here is a marketer, I wanted to start off with a definition of what brand is. So these are two common definitions. And, if you look at the second one, a person's perception of a product, service, experience, or organization, that is really what Sandra and Jackie's team is doing with the Office of Patient Experience and also the educational materials that they're presenting. So there really is a connection between our hospital brand, which is Children's Hospital Los Angeles, CHLA, we of course use an acronym, and what the patient is experiencing. Keeping that marketing hat on, we have several touch points that we look at in our consumer or our patient family journey. And you can see at each of these moment of need when they're searching for, Googling that condition to search for help, set up an appointment, to actually scheduling the care, to when they show up for the appointment, where they park, how the wayfinding is set up, what interactions they have during the appointment, that ongoing care continuum, and then the recovery once they go home. And, all of those points involve health education and the importance of having content that people understand. And, that goes directly, as Sandra said, to outcomes, because we don't want to have people readmitted. Almost every marketing team is going to have a set of brand guidelines. And this is something that sometimes is just really internal to the marketing and comms team and may not be visible to the rest of the hospital or the institution. Within the guidelines, they usually address things like look and feel, colors, font choices, template design. There's usually some component of a style guide, notes around tone. You want to sound authoritative but not condescending. These are all aspects of that guideline. And then it also usually will get into things like licensing, copyright, trademark, photography style, because there's so many different ways that you can photograph. So sometimes, some hospitals want to focus on, cooler tones versus warmer tones in their photography. So these are all things that your marketing communications team is thinking about, and they probably do have these documented. So always feel free to reach out, if you have that relationship, and get that information and take a look at these brand standards. And something that we've learned, and I've worked over a decade in hospitals now. My background comes from journalism, but as we partnered together, we really started looking at okay, what's in the brand standards, and do they work in terms of being health literate? And a lot of these questions we started really asking when COVID hit, because we went from doing some communications that were patient facing to producing over 5,600 signs, posters, and materials that were throughout the hospital that, really, it was really important that our patients and families understood them, because, in the first days of the pandemic, we just, we didn't know what we didn't know, and ensuring that masking was, followed and all the things was so essential, and it was a huge safety issue for us. So we started looking at our brand guidelines, and these are really the 5 things that I think marketing teams can look at from an accessibility perspective. And, ask some of those questions, the types that you're using. Do you have Arial as an approved font? That's the most accessible font from a health literacy perspective, but is that part of your marketing toolkit and your brand standards? Has your marketing team reviewed the brand fonts? So when I say brand fonts, that's usually a fancy font that the marketing team has purchased, and not everybody might have access to it. But, it's the font that might be in your logo. It's the font that might be, in the big headers on your different pieces of print collateral. But if you look at that font and you took a ruler, how big would that measure compared to a 12-point Arial font? 12-point in one type of font is not the same as 12-point in another font. So that's just another thing to consider. Making sure that you have a good selection of iconography and consistent iconography that can be used across your digital platform, your print platforms, your collateral, your patient family education. So, and you're using the same icon across the board, and that will help with your patient journey as well. Looking at your PowerPoint templates and your different templates that you're using for patient family ed. When we first started our partnership, we spent, I want to say our art director spent a good several hours with Jackie and her team, just hearing them out about the challenges that they are having with the template that we created for them. And that led to us redoing all of our templates. And we did that with a few key things in mind. One is, did the templates allow for language expansion? So, everything we do, we translate into Spanish. So that is double, sometimes triple the amount of space that an English piece would take. Also, are you able to deal with languages that read right to left instead of left to right? Can that easily be flipped in your template? So that's another thing to take into consideration. Are they easy for a non-designer to use? And even down to little things like, is there a spot to mark the review date so that you can have version control and have consistent, labeling of things so that when a piece is printed out that it came, that it was within the past 3 years. Taking a look at your writing style. Talking to your writers and perhaps getting them to pull back a little bit from the long prose, bullet lists to your friends, looking at that as another thing that you can address. And finally, color choice. And I have an example to show you related to color choice. But one thing that we learned is that so many of our providers, our nurses, our frontline staff, they were printing these materials off of printers on the unit. In Marcom, we had developed, 4-color flyers, but the printers on the unit were black and white. So none of that color had any meaning once it was being printed on the unit, and it was just muddy gray. So, we adjusted our colors based on that. Also, as Sandra mentioned, it's important to partner with your print shop because they're going to be your front line. And they're going to get so many requests, and they can help, look at something and say, wait a second, this looks like, this does not look like something that they created, or maybe Marcom should know about this, or, has the patient family ed team used it, reviewed it. Along with color choice, this was Children's Hospital Los Angeles. This is our original color palette. You can see we've got pretty much all the colors of the rainbow, a benefit of being a children's hospital. And the thing is that these were designed to work in print. But when we started thinking about, okay, well, how does that work if we move that into a website and we start plugging these colors into web design, we find they aren't accessible. So this is a section of those colors. And this is plugged into a site called Contrast Grid. And if you can see all of these squares that have a red square on them, those are things that do not pass the accessibility test. And then the items, the blocks that have the little goldenrod yellowish box on them with the AA18, those only work if you have very large text. So you can see, as much as we loved all our colors, there's a lot here that they aren't going to work for us. So along these lines, I'm going to kind of dive into these 4 steps to structuring the partnership between marketing communications, patient family education, and other teams. And I always find webinars and sessions like this, I want to see like what's under the hood. So I'm going to show you a little bit about what's under our hood. So this first one that we have on our list here is aligning on what our policies and processes are. So we went through and, many thanks to Sandra and her team, they actually called and said, hey, Marcom, do you want to read over this content development guideline with us? And do you want to cross-link your policies with our policies? So we started pulling this all together and partnered on creating these documents, and we do our best together. That's one of CHLA's values. So we really leaned into that in this space, and we started pulling things together. So this here, the page that you're seeing here, this is from our patient family experience and engagement and experience SharePoint site. So this is an internal site, but you can see we've got our policies listed there. We've got, cues to get people into education review and submission forms. And we've got our marketing communication space as well. So we tried to put everything in one spot for people. We took this on a roadshow with our clinical services and management teams. And, we've routinely taught to this. Jackie teaches to this when she does our I-learns, when she does her in-services. So this is one of the first things that we did, was just documenting those policies and processes. We also had to do some role clarity because, sometimes it's like, wait a second, is that you? Is that me? Is that Marcom? Who, deciding who's the subject matter expert, deciding what falls under patient family education, what falls under marketing communications, and where there's something like shared responsibility. So this is really how we divided it up at CHLA. And you may have, it might look a little different in your institution, but just wanted to give you a flavor of what we were able to do. It's also very important that your providers, your frontline staff, they understand what the process is. So but starting with the policy, and then starting with clear workflows and, that you can communicate out. And communication is key, so key in all of this. So this is a workflow that we publish out to our staff. All team members can see this. And, this lets them know, so it doesn't disappear into some black box of like, oh, I want to do a mobile app. I want to, what does that look like? Okay, well, there's a process for that. And this also really helps streamline requests for custom content as well. So that's our workflow, and you're welcome to steal that. And then the final thing that we did is we've got really two content repositories. We wanted to make sure that after we had this approved content and templates and materials, that it was available to everyone. So within that patient family education and engagement site, we created a health library. And, this is great because people can sort by topic, by category, by, there's alphabetical order to it. So this is all accessible through the SharePoint. And we've also worked with our information services team to have a link to this site on the workstations on the unit. So our clinical providers can get to this page directly from the clinical workstation. Now, the marketing side, we also have a content repository, but we've been very clear in making sure that the marketing content stays in the marketing content, and anything that is patient family education is on that SharePoint site. So we collaborate between the two of us and make sure that we're sending people to the education site when they need education. And then when somebody wants to do something that's more of a marketing piece or collateral that doesn't have an educational piece to it, our patient family ed colleagues will send them over to Marcom. So this is a sample of our marketing communications brand portal. We keep all of our images in here. People can download these stock images for their patient family ed materials as well. So it really does provide a shared environment. And this, we use a product called WebDAM, so Digital Asset Management System, and it's a product by Binder. And now I'm going to hand off to my colleague, Sarah, who is also part of the marketing communications team.
Hello, hello. My name is Sarah Brown. I'm Senior Content Strategist at Children's Hospital Los Angeles on Kelly's team, and I'm going to talk a little bit about why and how we apply the principles of health literacy to marketing communications, kind of a little more the art, as Kelly provided all the detail and science. Next slide. Start with a quote from Woody Guthrie: "Any fool can make something complicated. It takes a genius to make it simple." And it's really so true. Being succinct is a skill, and it's sometimes a skill that healthcare providers do not prioritize. So why should we put all this into practice for our marketing materials? It's just one example. Something I've been working on a lot lately is our website. It's a marketing tool, but as Kelly noted, it might be someone's first touch point with your organization, and they may be encountering it when they're in a time of crisis. Studies show that simplifying your website improves the experience for all users, not just those with limited literacy skills. Clean layouts and familiar language are more usable for everyone. If we borrow the health literacy tenets for use in our marketing efforts, we make everything better. We improve the patient and family journey from end to end, starting with that very first touch point with our institution, like the website. Good content deconstructs the complex to make it easy to understand. The one I will point out here: no one will ever complain that you've made things too simple to understand. Occasionally a doctor or researcher will complain because they might think, you're making them look not so smart, or making their peers think that they're not good at the complex stuff. But try and remind them that the audience for the website and the content is generally consumers and not their peers, not their physician colleagues. Next slide. So all of those things were actually, they sounded like they were from a health literacy text, and actually they're from a marketing book. This is one that I really like, called Everybody Writes by Ann Handley. And it turns out that marketing best practices are often already health literacy best practices. Incidentally, I think Everybody Writes 2 comes out like tomorrow. So if you're interested in a good book on writing, there'll be a refreshed version coming up very shortly. And in healthcare, this is even more important because even the most educated user might be overwhelmed by the information and unable to process complex ideas when they're trying to find out what they need in a time of crisis, such as, an unexpected or serious illness of their child. Also, very intelligent, but a lawyer isn't a nurse. An astrophysicist isn't a medical doctor. They may be super intelligent, but they just may not know healthcare. Some writing tips that I can share, specifics from Ann Handley's book to create ridiculously good content. Natural breaks in text allow the mind to reevaluate the text up to that point. So like a sentence is where your brain stops and reassesses the content. So shorter sentences, shorter paragraphs. Jargon is one that we, really, we have to like step back and think what really is jargon, because I think things that we even think are plain language in healthcare aren't such plain language. One of my favorites is the word novel that our researchers love to use, like a novel therapy. A layperson doesn't really read this as the word new, but just say new. And also, we've mentioned before, but who doesn't love bullets? We all love to get, a well-organized piece of content that has bullets. And there are a few more things that I've learned from my health literacy colleagues that we've borrowed from their toolbox, which have been mentioned before. Grammarly, I love that it checks for plagiarism. The Flush Kincaid, which, as she mentioned, it's right there in Microsoft Word, and the Hemingway app is super handy the way it works. Right on your desktop to tell you like which words are too complicated, which sentences are too complicated. So hopefully we've laid out everything clearly and concisely in a way that you can understand. And I'm sure a lot of you already know the basic principles here. Sometimes the greatest challenge can be convincing those in your organization who don't know these principles. So hopefully we've given you some tools and nuggets to do so. Now tell the others. And I think we have a few questions in our Q&A. And if you guys have any more you want to put in, we have some time for questions.
Yeah, we do have a few questions. The first one, the initial health literacy trainings, in-services, grand rounds, I-learns, etc. Are these optional or mandatory for staff? And how do you recruit patients or family members into the advisory council? So 2 questions there. And Sandra and Jackie, I think that's for you.
Hi, everybody. I think we can turn or stop sharing the screen probably and pull all of us up. I do also have some questions that are over in the chat box I can see as well. Kelly, I think there was some technical difficulties with the sound, so I'm going to suggest I'll read and then, but I do think there's a couple questions that are specific to you as well. So in the first question that we were asked regarding the grand rounds, so these right now are optional. We have placed them on our SharePoint site or iLearn as an optional. We are in fact actually updating our hospital orientation as well as our in addition to updating our reorientation for all staff, which we are going to incorporate some of these health literacy principles and guide people to those iLearns is our plan. At this point, it is not mandatory, but we are working towards that through those reorientation, which is an annual review, or through the orientation onboarding process. And as Jackie said, it's been incorporated into some of the nursing as well as some of the physician engagement. I think that the other question was related to recruitment of patients or families for our advisory council. We do also recruit on our website. We recruit through clinical teams, educating our leaders, educating our team members about the importance of the family voice and patient family voice. So we do a lot of recruitment. Also, we've engaged our language and cultural team members and others as well, so that people who are in contact and in the front line are able to engage families as well as peer-to-peer engagement and recommendation. I think that the second question is one for Kelly and Sarah. What is the name of your DAM?
So
sorry, go on, Kelly.
Can everybody hear me? So we use Binder Webdam, so it's BYNDER, and for those who aren't familiar with it, DAM is the acronym for Digital Asset Management. So in a lot of marketing agencies and marketing shops, this is where your images, your final pieces of collateral are saved, and everything is tagged in there. And that kind of goes into the other question I see in here related to DAM about taxonomy. We actually have leveraged, we started partnering with Sandra's team on taxonomy for the patient family education site. And that taxonomy was based on diagnoses and conditions. We've extrapolated that, added a bit more to it, and we've now used that as the backbone for our digital asset management taxonomy as well. Additionally, we also have repurposed that taxonomy into a database we're developing for research studies, so that we have consistent taxonomy across all these different entry points where either a provider or a patient parent could be searching for something. So that answers, I think, our DAM and our taxonomy questions.
So I think that the next question, there was also a question about, do you have any resources for free images or icons, and what is the easiest process of obtaining image permission from websites? Okay. So
there are some sites out there that do provide free images. I am blanking on one of them. I think it's called Pixels, but I can pull that up if you want to share that afterward. At Children's Hospital Los Angeles, we do have a license with Getty Images. We have found that having that license is worth the money for us because Getty has a very diverse set of images available. So that really is a preference, and we've made the choice to go with that. They also, one of the nice things about Getty is they have sub-libraries for different themes. So there is a library that really focuses on LGBTQIA plus related imagery, a library that focuses on accessibility, disability, and accessibility images. So it just provides a lot of great options for a healthcare organization to have that type of license. Shutterstock also lets you download packs of images. So if you need to get, you'll need 25 images, you can purchase a quick license that way. And I saw in the chat, Pexel was the one that I was thinking of, and that it has free images that would all be licensed. In terms of obtaining image permission from websites, you usually need to reach out to them directly, or you need to reach out to, I do caution that though, because sometimes it isn't necessarily the institution's image that's on that website. It's actually licensed by the image creator, the original photographer, or the original designer. So that can always be tricky, and you can end up in a bit of a rabbit hole if you haven't sourced the image appropriately. One way to kind of not get around it, but to at least give yourself a little bit of legal cover, is to always include the source of the image that you've as part of your design. So for example, sometimes we will pick up an image from well, actually, I'm going to use one that we just talked about a couple weeks ago. We had a patient family one sheet about a squatty potty, and we needed to have an image of a squatty potty, which is, there are generic versions, but, when it came down to it, we weren't going to go out and buy one and take our own photo. So we did pull an image, and we just, made a note of where we got the image from. So if the company were to come back to us, I feel pretty confident from a trademark perspective that we've given them their due, and that will, cover us that way. But yes, I agree with Jane. Best practice is not to use any image that you haven't licensed or that you haven't taken yourself.
And then going back and reviewing, we have a lot of great links from Cindy Brock, who I understand is with she's added from the AHRQ URL and a few in the Healthy People links, which we really appreciate. She did add quite a few great links. Jackie has added some great links. A few people have asked about the algorithm. We're definitely happy to, we do have a PDF version. It was actually created in Visio. So it's not one that a lot of people, necessarily everyone has the ability to open and change, but we do have at least a PDF we'd be happy to share. In the slide decks, I believe, are going to be shared after the presentation. I know I also saw a question here from Carol regarding how do you avoid turning off staff when the process appears lengthy and complex. And sometimes that is a challenge, and we have to have open conversations, and it's new. A lot of people aren't used to circling the wagons, and once we did circle the wagons, we did have some teams that were not happy, and it's not necessarily even about the complexity of it, it's change. So it's really variable. Typically, we will have a conversation. We do have a patient family education consult. Our marketing communication team and our team will also meet together with teams. It's very united in our conversations. If it involves something with our language and cultural services team as well, we will engage them in the conversation. So just being really consistent and then helping guide people through. And through the consultations, we've been able to help manage that and support teams as they need it in navigating the process. We also have some I'm glad this has been helpful for quite a few people, and the reading exercise. I'm sure Jackie will be happy to share the reading exercise for you to have to share with others. I think other conversations, just going through these other questions to make sure we've answered everything. So we have only about 5 minutes left. I think someone also shared the HCEA guidelines, which we've also accessed and used. Another great resource, as well as with the IHA. So a lot of good teams. Happy to follow. We can put our emails in the chat to touch base. Does anyone have any other questions? We're down to our last 4 minutes, or if someone has another comment, you're also welcome to raise your hand. I did actually see, Kelly, so we have, how many custom PFE assets do you manage? So Jane, in answer to that question, we just did what we consider a clean house. So we had over 1,000 documents, and we've actually gone through, that included translated. We've now cleaned out everything that was more than 3 years old over the last several years, or the last 2 years actually. And now we are down to about 300 custom content that is currently within the last 3 years of development. So we are limiting, and in the same time, in parallel, Kelly's team, we're actually working on licensing patient family education content, particularly on pediatrics. In our review of other systems and healthcare systems, we're finding a licensing of content and then only having custom content that you need to supplement. We also mandate that all anything developed in English must be also done in Spanish at a minimum. And typically we do our top 6 languages. Are there any other questions? Or Kelly, did you want to add anything from a marketing standpoint?
No, I think that about covers it. We're all putting our information in the chat. The 300, do you see that, Sandra? Jane is asking if that's English only or if that includes—
That's English only. And that was after we did a mass clean out. So we had more, and some documents you have to keep in mind, for example, a tracheostomy manual was about 50 pages. So it's not everything is most things we try and get to a 1 to 2 page, but for certain topics, there's much bigger materials that are sort of done in sections. We do also have changed our practice that nothing, everything is a 1 to 2 page and could be done in separate sections. So it used to be they continued and had a very long continuous book. We've broken that down into sections and recommending. So recommending that everyone get everything down to 1 to 2 pages per section or per topic. And then I think someone said, how do you determine what languages? So we have a 60%, we have a very large population of Hispanic Latino families. And so knowing that we have that large population, we worked with our language and cultural services and our IS teams to pull what our language rankings are, and that's how we determined it was necessary due to the common nature of our Spanish speaking for monolingual families for Spanish. Our others in our areas, Armenian, simple Chinese, and Arabic, and I think Korean is the 4th one. And that's based on their very small amounts after. So the top 2 are English and Spanish. So that's why we don't necessarily translate everything into the others. And that's an outsource outside of Spanish. We can do some Armenian and some simple Chinese in-house, but most of that is done externally.
Yeah. And we've looped our translation vendor into our processes as well. So, you know, they are connected directly to Sandra's team, and then marketing communications, we direct only marketing related materials directly to translation. Everything else we make sure we run through Sandra's team so that it can be vetted for literacy before we go into translation.
And I think we're down. We are now out of time, and really appreciate everyone's engagement and participation. And thank you for time for spending with us this evening and the afternoon.
Thank you.
Thank you.
Thank
everybody.
you.
Yeah.